Hi, my name is Nico. This is video 2 of the abdominal assessment assignment. This video is going to consist of differential diagnoses, including pertinent positives and negatives. I will be starting with my two that I have identified to be the most life-threatening, and my last one will be the least life-threatening. I do have reference notes in front of me, like I mentioned in my prior video. However, I will not be reading from them as a script. I will occasionally be glancing at them, however. My first differential diagnosis for this patient, which I believe is the most possibly life-threatening, is a AAA. First positive being the presentation and pain being upper abdominal radiating to mid-thoracic back, and the increase from 3 out of 10 to 1 out of 10. Now, not all aneurysms are painful and every patient presents differently. However, if we have a large aneurysm, this could be causing some pain for the patient and some discomfort. My next positive is the elevated blood pressure. However, that does require some more testing and some more exploration, which I will go into detail about in my final video for my specialized assessments or tests. My next pertinent positive is shortness of breath, followed by the presence of nausea and vomiting, and the presence of the clammy skin that we see when we approach our patient. My pertinent negatives are the patient doesn't have any large changes in blood pressures, or would be once I do my final specialized test in my final video, as well as the symptoms that presented along with it, the loss in appetite, the slowed bowel movements, or the lack of bowel movements, in the past couple of days, the pain after the oral intake, and as well as the history of the chief complaint having started 7 days ago without a progression to a rupture or without having without a progression to a ruptured aneurysm or a change in the description of the pain. My next differential is a perforated bowel secondary to a bowel obstruction. Now, the reason I believe this could be life-threatening is because the possible infection that can follow a perforated bowel. My pertinent positives are the pain post the food intake, which could potentially be from the blockage, as well as the upper abdominal pain, which could indicate a possible blockage in the transverse colon, as well as the tachypnea, the lack of a bowel movement within the past 3 days, and diverticulitis could potentially also, the history of diverticulitis, because diverticulitis, depending if the patient has a history of chronic inflammation, can cause a blockage, which can lead to a perforation. Now, my negatives for this are the patient is not tachycardic, he is not hypotensive. As I explained in my final video, I'll be testing for peritonitis, which there is a lack of. The patient doesn't have a history of chronic inflammation from what was presented in the case study, and there is no global abdominal pain, and the patient is not presenting with a fever. Now, moving on to my last differential, being cholecystitis leading to pancreatitis. Now, the reason I believe this is the history of fatty foods, the alcohol consumption, depending on how much is being consumed and how much fatty foods we're talking about. Of course, all of this would require more exploration in patient history. That being said, the reason I believe this could happen is because if there is a gallstone that is blocking the part where the bile duct and the pancreatic duct join together, it could cause a blockage in the pancreas, leading to a pancreatitis. Now, my positives for this are the right upper quadrant pain. Now, it is pain secondary to the initial presentation of left upper quadrant. However, it's something that does have to be tested and ruled out to ensure proper treatment. As well, my next positive would be the pain radiating to the back. Not necessarily present in every patient, but it is something that can be common, especially in the right shoulder blade area. And my last pertinent positive for this would be the presence of nausea and vomiting. Now, my pertinent negatives are, as I mentioned earlier with some other tests, I will be performing a Murphy's test in my final video, which would be, if there is a negative Murphy's test, it would indicate that there is no cholecystitis present, as well as the patient does not have a fever and there's no presence of jaundice, which not necessarily present early on, but can be a late sign of cholecystitis.